All right, here we go. Good afternoon, everybody. This is Rolando Mia with Zyris. I have a special guest today. I'm really excited to spend some time to speak with her. Everybody, if you don't know her, you will know her by the end of this. This is Michelle Strange. We
Hi.
met, we met a little bit ago, and before I start asking you questions, I just want to say a couple things. First of all, Michelle has an incredible passion for dentistry, for her craft, for hygiene, for basically anything dental. She considers herself a dental nerd. She runs a podcast, A Tale to Hygienist, where I believe she's got over 200, like 220 or so plus episodes, and they are incredible. If you have a
Oh,
chance to,
thanks.
it's a wonderful forum, and you can hear from so many different people. In addition, she lectures. She's written a whole host of different articles that I've had the pleasure, and now talk about crazy, talk about apropos to what's going on here, are very relevant material to what we're doing today. In addition, she is a serial workaholic entrepreneur, loves this industry. She's got triviadent.com. She works with Dr. Tony Stefano. She works with virtually everyone in the industry that has a space in here, and we're very thrilled to do that. So Michelle, thank you and welcome, and appreciate you taking
Yeah,
the
no,
time.
thanks for a great introduction. And it's so true. I am obsessed with this profession.
And I didn't even have to make anything up. So I was like, oh, wow. So
No.
what I'd like to do over the next, 20, 30 minutes or so is basically spend the time. The purpose of this session is to talk to you specifically about something that you've been a passion and you've been very, very much a champion of. And that has to do with infection control, specific to dentistry, but it's also across the entire spectrum of all of the different areas of dental procedures. Could you please just kind of give a summary of how you would define infection control in dentistry and its effect on things like aerosols, viruses, diseases, all those types of things? How would you kind of summarize that for us and our viewers?
My dog wants to come be in the
Oh, it's your dog's
video.
name.
Lola,
Oh,
my baby. So, I've been, I would say I'm new in the infection control. Like I've been dabbling in it for a while. I've always been a little bit of a clean freak, especially, and I've worked in surgical practices. So, I started out as an orthodontic assistant, on the job trained, where I didn't know what I didn't know. And I probably did some horrible things, but luckily it's not like a lot of blood, even though saliva is infectious. There was not a lot of blood everywhere. And so, I had some horrible infection control practices. And, again, I didn't know what I didn't know. And then I went to hygiene school and my eyes were wide open, and I had quite a few faculty members that, they didn't let you get away with a darn thing. So I learned very good infection control procedures. And then I went into a surgical practice where I, really had to implement that because we were doing, major jaw surgeries and implant placements, and then I got to do the surgical assisting and the dental hygiene side of it. And then I went into another perio practice where the periodontist had a just amazing infection control. So it took the neat freak, clean freak that I was to another level. And, when I went to a course very early on for continuing education, and Olivia Wan, it was the speaker. She's been on the podcast a few times. She doesn't know how much she intrigued my passion for infection control, even though I don't know if I've told her enough that she's kind of the one. But I heard her speak, and she did it so great and so relatable. And it was probably the first time that I wasn't like sitting through it feeling like it was just so dry and or horrible, like, ugh, I got to get through it. And I was like, oh my gosh, I love infection control. I want to talk OSHA. I want to talk about these things. But it took me quite a few years to get to that, because I mean, that was probably 12 years ago. And I really, kind of diverged a little bit and went into the world of dental implants and home care and biofilm management at home. And, I did that for a few years. And I started doing some side research for a company that is now on the market and actually kind of popular right now, O2 nose filters. And I really delved into the aerosol research for them, like looking at, the aerosols that we produce in dentistry. Because when they gave it to me, I was flying with it. I was flying with these nose filters. And, because I was getting sick in the very beginning and I was like, I'm on these planes way too much. I'm going to start wearing these nose filters. And then I was like, y'all, this would be amazing for dentistry. And they're like, really? Do you think dental people would want this? I was like, are you kidding me? Like, but again, I'm the weirdo in the office that's like, watching people touch things with gloves versus clean hands. I'm like, wait a second, what's the protocol here? Are we touching with things with dirty hands? Are we touching things with clean hands? So me being the weirdo that I was in the days, they were like, is it just you that would wear it, or would every dental professional wear it? And I was like, I don't know. Let me do some research. And that's kind of when I started delving into aerosols and spatter and spray, and how, we're the biggest producers of that. And yeah, so I've been kind of not so much in infection control as much as I am now, because where I'm working on my credentials for through OSAP and DANB to get my, like a real certification to be a provider of infection control training in OSHA. But I was kind of dabbling in this aerosol world, and I was like, this is insane. Why don't we talk about this more? And so, I eventually got a little bit of a voice in the profession, and I've been kind of preaching it for a while, though I don't know if anybody was really listening a few years ago.
Well, it's interesting. I've read several of your articles, and the context that you have around infection control is so comprehensive, because it involves understanding the process. It involves all the different types of diseases. And here's the thing too, I believe you're clairvoyant, because there was an article that you wrote a year ago before this entire crisis that we were getting into. And in addition to talking about bacteria, in addition to talking about airborne biologics, in addition to talking about all of the different kinds of diseases that are out there, you actually mentioned straight out coronaviruses, SARS, and all that.
Yeah.
And then you also have been very much a proponent of educating around this idea of aerosols. Help me understand, and if you would, hygiene is a key area that you are a hygienist, you're still practicing, and it's one of the areas where I believe, from a dental perspective, the majority of the procedures are done in hygiene. And there's an ultrasonic scaler in there, and I've even heard that people are being told not to do that, or maybe later on. Help understand kind of the aerosol issue in hygiene, and then also with regard to, and then also clarify spatter and splatter. What's that?
Okay, so I actually did get a really good way of describing this, spatter versus splatter. So you have blood spatter, and that's what lands. So splatter is what comes out before it lands, and once it lands, it's spatter.
Okay.
So they're essentially the same thing. One's just airborne and being in, what's the word, like
flying
out. I can't find my word, but it's in the world before it lands, and then it becomes spatter. So you have spray, splatter, spatter. It gets a little confusing. Aerosols, and then aerosols. Some are heavy, some are big, some are like large microns. Then you get them all the way down to teeny, tiny, microns of like anything lower than 2.5 microns is considered very small. And so anything above 10 is considered a little bit larger. And so it's a little confusing. Like if you're not diving into it for like to learn it, I mean, it does get the nuances and the words. It feels very nebulous, and you're like, I don't even know what they're talking about. And, I even have that, like I had to write a chart at the beginning, like this is this size, this is that size. It's a little much, but and hygiene it's a creator of all kinds. I mean, every particle of every size, because we're doing air, water. We might be doing polishing with pumice. We might be doing air powder procedures. We might be doing ultrasonics. There is just so much. Even somebody just spitting their pre-procedural mouth rinse in the sink, or if you're having a cuspidor in your operatory, or and people do
cuspidor. What's a
cuspidor? Is that little sink that used to sit next to it, right? I've never even seen one. I've never even practiced with one ever. That's like not a big popular thing in Charleston, South Carolina, where I'm at. But even when they like spit into that creates all kinds of spatter. So it's a thing that we really need to be concerned about. And, bloodborne pathogens is 100% an issue, but I think we're all pretty good about bloodborne pathogens because we had the, HIV, AIDS,
Right.
scare in the 80s. We started wearing gloves. We have safe needle practices. We had like a needle practice act that made sure that we used sharps containers and safe engineering controls. But, the thing that I feel like gets forgotten about is the aerosol management, aerosol standards. And, we do have these engineering controls that are high volume evacuation, and that we should be using those to control aerosols. And I learned with magnetostrictive. That was my very first thing using. And then when I went into my perio practice, the hygienist that was there with me and was doing the full-time stuff, she used the Profijet all the time. And, I learned to love it. And so I used every single patient for, a strong decade of my career, Profijet, followed by Cavitron, followed by hand scaling. And, I was done. So I was using aerosols, and, I used to have the face shield and my face would be just, dusted with all kinds of stuff. And then I also suffered from a ton of respiratory infections, and which is kind of why I think I feel like I'm very evangelic about this, especially with hygienists wearing the proper PPE, the proper mask and the level for what they're doing, and using high volume, because I suffered from probably minimum of 6 sinus infections a year, bronchitis. I would get laryngitis at least 2 to 3 times a year, which my patients always did comment on. They're like, "Great, you can't yell at me about my toothbrushing now." And I'm like, "You're right. I can't even speak to you." So I was suffering from it. And I honestly, I didn't know what kind of mask I was using back then. I was unaware. These were not things that were brought to my attention on a regular basis, maybe in my 1 CE that I would take every 1 to 2 years, but that was it. I was definitely guilty of reusing my mask. I was definitely guilty of probably cross-contaminating myself quite often. So all the things that I talk about, it's not because I'm so perfect I didn't do them. It's because I suffered from all the things that were occurring because I was doing these things. So I definitely talk about them because I think upper respiratory infections are huge amongst, dental professionals. And there's these studies out there that people have been doing about aerosols and idiopathic pulmonary issues that adult dental professionals have, but no one's really talking about it at the same time. So, but it's not sexy. It's not lasers. It's not implants. It's not, the composite that makes your restorations better. It's not sexy and fun. It's like, oh, gross. Like, why do I want to talk about personal protective equipment?
Michelle, I believe after everything that's going on now, when we're through this, your life is going to change because there's going to be a lot more attention to it. You mentioned HIV.
Mm-hmm.
And one of our clinicians, Dr. Hirsch, mentioned that, like that entire situation, it was a paradigm shift after that.
Yes.
I believe that the same is happening now. You mentioned, upper respiratory infection. That's not just with your hygienist. That also, I believe, occurs with the dentist, with the dental
Sure.
assistants and
Absolutely.
members of the staff. How would you, if you were to look at it from a we have a lot of listeners here, and people are going to review this after. What is today, what should minimally people be doing now, and then what should they start considering as things that have, because it took a while to get here. Where do they need to eventually get to? What advice or what education, I'm going to call it that, would you give us regarding that?
Well, I would definitely say take whatever I say with a grain of salt now, because in an hour it could very much change because we're just learning so many things so rapidly right now. I hope no one is seeing dental hygiene patients at the moment because that just seems dangerous. But I would say if I had looked at like what we should have been doing prior to this, before we went into a shutdown, high volume evacuation every time you're using any kind of ultrasonic air powder. And I would even say your pumice and stuff too, because that just spins around and throws it into the air. I mean, granted, those are heavier, so it's going to land, and then you can deal with it with your environmental infection control. It's not, or it can land on your mask and you're just going to remove it and take it off. But those aerosols that linger in the air, for me, it has always made so much more sense to get them before they get out, out past, the mouth and into the air and into the operatory where they can float around and go into the hallway or just be hanging out there until the next patient walks in. And that's the thing I didn't understand. I was like, I'm trying to explain to y'all. These things linger. So if that person had the flu and now, I'm walking. So that's the thing, is like, we always kind of put this stigma on people that weren't like clean, like, oh, they wouldn't have anything communicable. They wouldn't have, HIV, or they wouldn't have hepatitis C. I'm like, but what about the damn flu? What about a cold? The common cold, like, and again, the coronavirus, like, is a part of that, like, common cold line. So, like, what about that? Like, why wouldn't I be concerned about those little things? And also, I think when we aren't using high volume, they breathe it in. So, like, we're just throwing it in. We're forcing them to breathe through they should be breathing through their nose anyway, but because we're in their mouth, we're definitely forcing them to only breathe through their nose. And they have no option but to breathe in all of the junk that we just brought out of their mouth, and it takes it into their upper respiratory tract. And, I don't know if I couldn't find any like super hard data on that and like science, and no one's really reporting to the CDC if they get a cold after they go to the dentist. But we have a lot of those anecdotal experiences where patients come back and they're like, I get a cold every time I come here. Like, I get a sinus infection. There's one even lady that Ann Guion wrote an article about that would tape gauze over her nose during her dental appointment. And all these hygienists were like complaining, like, what kind of crazy person is this? And I'm like, she might be onto something. She might be doing something. So I think high volume, to go back, I'm sorry, I digressed, but to go back to that, I think high volume 100% should be used. And it's awkward, and I get it. And you got to work through that. You got to train through it. Definitely proper PPE, pre-procedural rinses, like getting that patient to rinse and decrease that bacterial load as much as you possibly can. And then continue excellent environmental infection control and barrier wrap everything you possibly can, so you don't allow cross-contamination.
Wow. Thank you for that. Appreciate that. It's kind of this idea of taking what has been done, being very much more aware of it, being more particular about it. Where do you see this thing going eventually, or what are your thoughts on it? You mentioned earlier, you said a term, biofilm, and I believe biofilm is something that grows when things land on it. What is that?
Well, biofilm is what is in the mouth. That's what we're contending with. That's what creates a lot of the oral diseases that we're, trying to prevent or fight against and bring them to a level of maintenance or secondary prevention. So, but a new term that I also heard, which I love, that Dr. Tom Larkin, I heard talk about, was bioaerosol. So it's the bioburden, the bacteria, the pathogens, the germs, if you will, that are in the aerosols. So even our lasers, that we do, there's that plume, that smoke that comes off of it.
Right.
They have found that there's, living pathogens and viruses in those. And so we got to control those. So from here on out, I mean, if I had a crystal ball and I can make some guesses, because I don't really know where this will absolutely go, but I think we're going to really look at 100% high volume evacuation, which Washington State was moving in that direction. If they haven't already passed it, they were pretty close to it, where if you're using ultrasonics and anything creating aerosols and splatter, you should be using high volume and wearing the proper PPE, minimum of a level 3 mask. I hope. I'm to a point where I just don't even understand why you would have a level 1 mask. Like,
Not just a tissue.
Yeah, exactly. Like, I mean, I just don't even know why. I guess if you're like looking at real pennies compared to, like, if I choose this one for x-rays over this one and I save like 10 cents, I don't know. But I'm like, tell hygienists, like, if this is the issue and you're having a hard time like getting that level 3 mask, a box is not that much. And honestly, it's less than a copay at a doctor for when you get sick. I mean,
That's
it's a copay and it'll last you. So just prevent the problem that you could probably then take to your family and get them sick as well. So I think minimum level 3, possibly N95s. And the thing that about N95s that I think everyone like Crosstex has ones that are actually more like ear loops. So they're not like the ones that like are like suctions to your face. But my God, people, let's learn how to wear those masks properly. Don't put them on your chin. Don't wear them below your nose. They are meant to fit properly along your face. There's a lot of, I think I would like to see that we go to fit testing for our mask to make sure they fit our face properly. All this twisting of the ear loops to make sure you get rid of that gap. Like, no, if you have to do that, you got to find a mask that fits your face properly. And then I think even looking at things like HEPA filters and cleaning the air a little bit better in your operatories and just, managing your surfaces and barrier wrapping things a little bit better and doing better environmental infection control. I do believe those are just very few of the future things that we're going to see.
Thank you. That's wow, incredible. And we are seeing a lot of those types of things. There was a podcast that was recently put on by Dental Town with Hart Fran and Dr. Rella.
Yeah, I saw a part of that.
Constant evacuation. And you also mentioned how important that is with regard to managing the aerosols, with regard to managing any of the I guess the bio load, or I don't even know how to mention it, and the different sizes of the aerosols that are out there.
Yeah.
I think all of that seems amazing, and I think that's cool. You currently are still, well, you were up until this point, until everything was shut down, treating patients with for hygiene. Is that correct?
Correct. Yes.
And the focus of this is around that, but it's also the advice, it sounds, that you're giving us it does permeate also through to the dentists, also through to the dental assistants, and
for sure.
And does it even include potentially people in the office and the rest of the staff?
Well, I think also we talk about patient care, but there's also a lot of aerosols produced in the lab. And we have to think about that as well. And I know you don't have a high volume over there, but wearing proper mask and protection, and maybe even having an evacuation system somewhere, or at least better filtration in there. Because when you trim your models, or you're carving out that denture and you just got all those, that acrylic flying in the air. Man, I used to, when I was doing being a dental assistant, when we would do night guard, repair and delivery, I should say. And I remember having to blow my doctor off with the air water syringe because he would just get dust all over him. And I'm just constantly blowing it around, just because I'm just sitting there waiting for him. And, then, that patient could be breathing that in. If somebody just walks in, and this is the other thing too, I would say, because I was guilty of this, and I know my front office was as well, but if we were working with a sedated patient, and maybe the front office would come in and be like, hey guys, your next patient's running 15 minutes late. And we're just in there cauterizing, doing lasers and stuff. And they're like, oh, okay, cool. And they're looking around. I mean, they're just breathing in that stuff. And we know aerosols don't just stay there. They're floating around, especially don't have really good evacuation and filtration. And you get the air blowing, and it's going to go down the hallway. So yeah, you got to do all these things, not just for that you doing the procedure, the patient in the chair, but for your team as well.
That's great advice. And it is, again, a paradigm shift in the way people are looking at infection control and how to manage it, and how to ensure that that bacteria, the splatter, spatter, spray, aerosol doesn't kind of go all over the place.
Exactly.
So I need to ask, do you use, you're familiar with Isolite? And that's how we first met.
Yeah.
Do you use it? And the idea here is this: it's not just it's about anything that's going to give you basically continuous evacuation. Is that right?
Yeah, so I do. I don't use it on every single patient. I definitely kind of pick and choose which ones. Definitely for my longer procedures, like my half mouth, non-surgical care. I work in, a lower income, and like I'm an outreach program. So a lot of my patients are migrant workers, and I don't speak 100% Spanish. I speak some broken dental Spanish. So if I have that communication issue, I don't use the Isolite because I mean, it does take some guidance to like what to expect. Here's how I'm going to size you, you know, move your tongue, whatever. And I'm not there yet in Spanish. So I don't do it for those patients all the time, unless I do have a translator that can come in and help me if it's like for a long procedure and kind of like give them the heads up of what that they're going to have their mouth propped open for a minute. But even then, I have the Isolite in mind because I also share my operatory on the days I'm not there with endo and with the other docs that come in and do cosmetic stuff. So we have Isolite. So that has a second hookup underneath it. I don't know what that little box is called underneath it, but
Yeah.
there's a second one. So I actually will run my second high volume to get that anterior portion where the aerosols are coming out, because I do believe the Isolite is sucking kind of the bigger stuff down to it and some of those little guys too. But when I get to the anterior, or I'm having to come up, especially like so I use Airflow, which is a erythritol powder for biofilm management. And I'm so in love with it. I will never give it up. So I'm determined to find a way to control aerosols because I'm not going back to the old school hand scaling ways only. So when I blast that from on the lingual surfaces, like that's coming back out the mouth. And I don't care how, what you got on the back there. Like I'm going to get some, but I'm going to miss a lot. So I hold the extra high volume on the facial aspect to catch as much of that as I can. I also use something that's a bracelet. Actually, I think I brought it home with me, but it's called Cord Ease, and it holds my high volume in here. So it kind of takes the drag off of my wrist as well.
Oh, yeah. Yeah.
And it's, I enjoy Isolite because I'm not drowning my patients, because that's my problem. And I know that this is a level of issue or concern with a lot of hygienists, is that it's the pooling in the back of the mouth and the aerosols. It's like they're either drowning or you're throwing aerosols into the world. And this is the dichotomy of seeing patients. Like, how do you handle this one or that one, this one or that one? So you have to use two devices right now. In my opinion, I don't have that perfect solution. I don't think you have that perfect solution for every single patient. And it's going to be different and very procedural based, and also patient tolerance of certain products. And so you just kind of have to go back and forth. I do occasionally use my low volume with a high volume, but with that, you need to make sure you have good backflow preventers on your low volume so they don't suck the spit back out. Because if you were to go across and that gravity in that suction kind of came back in there, and it 1 out of 5 is the number I'm learning. 1 out of 5 people get back the grossness from that suction back into their mouth, which makes me want to vomit. So I believe 100% in backflow preventers. But I think it's more about with the procedure that you're doing and the patient's tolerance and your capabilities. But I'm a big fan of the Isolite for that reason, because it makes sure it takes the drowning patient out of the game.
Yeah, and we've recently learned too that it's also, because it is constantly evacuating, it can definitely help. I love the idea of including, a lot of times people say, I don't need, but including the HVE in there with it to maximize anything that's being thrown out, which is huge.
Yeah.
That's huge. So purely from a patient perspective, what message, because what's going to happen is this, with what's going on, our patient's going to feel fearful of going back into the practice. Our patients, it's already hard enough, and I have to confess, for patients to come back for their their procedures like I don't. And what message would you give them regarding, hey, here's what you need to understand, and here's the kind of the information that you need to know.
Right.
What would you tell a patient about that?
I think we as a dental profession really need to up our game in communication especially with our patients. I feel like we have definitely always approached our care as, I'm the clinician, I'm the expert, and this is what we're doing. these are the things that I'm doing to you. Just like open up and let's get it done. You put yourself here. Like we've kind of come at it from this, I am the expert. And I think we just need to have these very open, transparent conversations, listen to the patient's concerns without like giving advice right there in the moment. Like if they're like, oh yeah, I'm afraid of the coronavirus, blah, blah, okay, what part are you, concerned about getting? Is it, because I'm doing these procedures? Is it because you thought the patient before you had it? Find out what it is so you could have a conversation versus just kind of like, these are the things that we're doing, blah, 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 and they didn't even ask for 90% of what you just gave them. So have a very open, transparent, open-ended conversation with them and get their feedback, understand their fears, understand their concerns. And if this is something that you're changing, I think you should have that conversation with them. So hey guys, you're going to notice some different procedures in our practice. Just a heads up, we are here to answer any of your questions. We are always on the edge of research. We always, want to include new engineering controls that keep you safe and our team safe. So these are the whys behind the things that you're about to see as you come back to our clinic and start getting these very important procedures and dental maintenance and preventive preventive measures done at your dental office. I think it's super important to have those conversations, and address them and acknowledge them, and really knowing your patients and who they are and like what they want to hear. One thing that I'm learning right now and trying to really delve into is disc profile and knowing are they people that need like hard fact science, like they don't like change and they need 100 reasons for that why, or are they just like, all right, you're doing it, that's great, all right, like if you gave me like X, Y, and Z, your why makes sense to me, I'm there. Like I don't really ask a lot of questions unless your why just seems a little weird. So just know who your patient is and what their concerns are, and just it's all about communication, I think, especially going forward. And establishing that dentistry is important. It's totally super important. But right now, these procedures that aren't emergency are being put on the back burner. And when it's time for us to open back up, you might notice some different protocols and procedures and things that we might ask you to do, like rinsing your mouth out for a full 30 seconds before you sit down in the chair. Here is why. And we're happy to expand on that if you have more questions.
That is great. Really appreciate that. Holy cow. So when you look at this space, you have been a passionate champion for a long time. And I would encourage anyone who's listening right now. There are quite a few articles that you've written. I've read them, and I'm blown away by how much information and how much research you put into there. So really excited about that. You also, I think one of the things is you in your podcasts you do cover, and you are a champion, a dental champion, not just hygiene, because I discovered that in your hundreds of podcasts you're covering so many different aspects of dentistry and what's involved, and I would encourage people to look at that too.
Thank you.
What final words would you like to kind of give our listeners and the rest of the folks who are going to be watching this after this, to kind of close this out? What you want to tell them, Michelle?
Where I'm at today, and I feel like it changes every day. I feel like I keep reading people, hygienists, dental practitioners, a little afraid of going back and like, oh my gosh, should I just go back to hand scaling? Should I do, I would be very cautious about slingshotting backwards too far. I think it's totally reasonable to be a little uncomfortable going back and thinking about things like, am I going to get sick? Am I going to bring it home to my family? Totally reasonable fears at the moment, but I think you have to work through them and really kind of walk into your practice with fresh eyes. Just reassess your protocols, your procedures. This is a fantastic time to really rethink your standard operating procedures in infection control and aerosol management. I think that you're going to want to lean into the comfort zone of I'm just going to hand scale it. I'm just going to, I'm going to do very little stuff, but that's actually not the best. Like our standard of care, what we were really learning was hand scaling is not the end all be all. It's biofilm management, and that creates a lot of aerosols. It's about using the engineering controls that have been established already in your practice to keep you safe. And just remember that you are an amazing dental professional that can train through the awkwardness. We started not knowing how to put our hands in mouth. Now you could probably do it while you sleep. And so just remember, anything that is going to be new after all of this, you can train through it. You can become good at it. It's going to be so awkward and horrible at first, and your very normal pattern routine little world is going to be kind of, torn apart for a minute, but you can do it. You got this. Don't worry. Just, think rationally and just come into the op with new, fresh eyes and ways that you can make and better changes for the safety of you, your team, and your patients.
Awesome. Thank you. Thank you so much for that. And thank you for taking the time to speak with us.
Yeah.
I look forward to seeing more of the things that you do and watching your live videos and your podcasts and your articles and all. And yeah, really very much appreciate it. Thank you for taking the time with us, and please stay safe. And it was a pleasure. It is a pleasure.
No, thank you guys for bringing me on. I love it. Thanks for having a place for us to chat.
Awesome. Thank you. All right.